What's going on, everyone? Welcome to the last video of the renal series. Today we're going to talk about renal failure, which is either incomplete or complete loss of renal function, mainly the failure of the kidneys to properly filter out waste and water from the body. Now, the two disorders within this video is AKI, which is acute kidney injury, and CKD, which is chronic kidney disease. Now, both of these disorders represent renal failure in one way or another, and when discussing renal failure, we're going to want to keep in mind the term glomerular filtration rate, because this is affected tremendously, which is why complications will occur. So we're going to start with acute kidney injury, AKI. And this is an acute disorder, meaning it is reversible. Now, it's the rapid loss of renal function, and older adults are more prone to contract AKI because their nephrons decline in number, and nephrons, guys, are what is vital for filtration, and there are millions of these nephrons within the kidneys. Now, if AKI is not corrected, it can progress to CKD, which is that chronic kidney disease, and this is the second disorder in the video. So examples of manifestations for acute kidney injury are things such as oliguria, which is a decreased urine output due to the disrupted filtration. Also, uremia may be present, and this just defines the decline in renal function, which involves various body systems. So guys, there are three major categories when discussing acute kidney injury, and they are pre-renal, which describes factors that reduce blood flow to the kidneys. We're going to treat this phase with diuretics to help get fluid out of the body. Next is intrarenal, which describes the damage to the kidneys. So you guys can think intra, inside. And lastly, postrenal, and this is the obstruction of urine flow, which is going to contribute to the decline in urine output, that oliguria we just discussed. Moving along, there's also four phases when discussing AKI, and they are the initiating phase, and this is the beginning phase where the ROS system is initiated, the renin-angiotensin-aldosterone system, and fluid will be retained to maintain blood pressure. Next is the oliguric phase, and this describes exactly what's happening here. This is going to be a decrease in fluid output, which will cause fluid back up, equaling excess fluid within the body. And remember, guys, oliguria is urine output less than 400 milliliters per day. So this is a decreased urine output. Normal urine output is 800 mLs to 2000 mLs per day. Now, the fluid is built up because of inadequate filtration and excretion. So here in the oliguric phase, there's also going to be a buildup in electrolytes and labs, such as bun and creatinine. The glomerular filtration rate here is very low, which is why there's a buildup of all of these things, because nothing is being filtered out. So there's going to be hypervolemia, increased fluid volume. Now, the next phase is the diuretic phase, and this is the phase of diuresis, which is actually a good phase because it shows that AKI has been corrected and things are actually being filtered out through the kidneys, hence the word diuretic. Now, it is in this phase that the patient can experience major fluid loss, leading to hypovolemia and electrolyte imbalance. So we're going to want to monitor for that in the diuretic phase. At the conclusion of this diuretic phase, the acid-base balance, electrolytes, as well as bun and creatinine levels, they will begin to normalize. And our last phase, guys, that of the recovery phase, which is when the kidneys return to normal function, meaning the glomerular filtration rate, that GFR rate, is increased and our labs are normalized. This phase can take up to a year to finish. Now, the nursing management for AKI is going to start with managing the manifestations. So remember, there is a decreased glomerular filtration rate, so nothing is being filtered out, which is going to lead to edema, shortness of breath, probably due to that ascites. Also, jugular vein distension and hypertension. JVD, that jugular vein distension, due to the fluid overload. And in order to get that fluid out of the body, medications used are things such as diuretics, which are our Lasix or our Bumix, those loop diuretics. We're going to want to restrict sodium and potassium because these are not being excreted, and we're going to want to also monitor the electrolytes when giving the diuretics, because when we lose fluids, we also lose electrolytes. Lastly, we're going to check labs to make sure they are normalizing, or if they are not going down, which will point to further backup within the body. Here are some more interventions we're going to want to implement, such as the monitoring of vitals and urine output. it's more than likely going to be low, less than 400 mLs per day, which is oliguria. And guys, being that these patients are hypervolemic due to the inadequate excretion of fluid, daily weights throughout the therapy is going to allow us to see if there is any fluid loss, or fluid is being maintained or is worsening. Next, providing oxygen as needed is important due to the shortness of breath, and checking the breath sounds, because remember, when there is hypervolemia, there may be fluid within the lungs, which is characterized by crackles upon auscultation. We're going to want to manage fluids throughout the day as well as the foods the patient is consuming, because remember guys, we want low sodium and low potassium in the diet. Also, low fluid, restriction of fluids. We're also going to administer meds as ordered, such as diuretics, and we're going to want to instruct these patients to practice deep breathing with that incentive spirometer, which is going to facilitate proper inhalation and exhalation, furthermore bringing up or getting out the mucus within the lung field. Now remember, if acute kidney injury is not corrected, it will lead to our next disorder, which is chronic kidney disease. Now, chronic kidney disease is the irreversible loss of kidney function. It is irreversible. And the most common causes are diabetes and hypertension. So when discussing CKI, it is characterized in 6 stages, but we're going to break it down into 5 stages, and they are represented by the glomerular filtration rate, the GFR. Now, here's a look at the stages of CKI using the 5-stage ladder of the glomerular filtration rate, and GFR, again guys, measures the amount of blood that passes through the glomeruli, furthermore filtering waste from within the blood. Now, GFR's normal range is 90 to 125, so keep that in mind. I put it below to the left of the screen. Now, the higher the rate, the better in terms of filtration, guys, and the lower the rate, the lower the filtration. So we're going to see that with each stage as we progress down the ladder, the rate starts to slow. And remember, the slower the rate, the worse it is. So at stage 1, the GFR is greater than 90 milliliters per minute. So we're getting out a lot of stuff, and this is good. This is not necessarily bad because the normal range is 90 to 125. In stage 2, the GFR now decreases between 60 and 89 milliliters per minute. In stage 3, it drops even further to that of 30 to 59 milliliters per minute. And this just points to a more and more decreased filtration rate. Next is stage 4, and the filtration rate gets even worse, 15 to 29 milliliters per minute. And last, stage 5, which is end-stage renal disease, the filtration rate is less than 15 milliliters per minute. And this is the worst it gets. This is end-stage renal disease, ESRD, stage 5. So here are the clinical manifestations with chronic kidney disease. And guys, it's all going to be rationale from here on out. So whatever we know that the kidneys do, just think they are not doing it. So let's start with the left side of the diagram. There's going to be an increase in sodium and water within the body due to the lack of excretion. And this is going to start the roller coaster for us, okay? So follow along. If there's a buildup of fluid within vessels, there is going to be increased pressure within the vessel. So against the vessel wall will be buildup fluid, causing hypertension. And being that there is a buildup of fluid, this will equal an increased vascular volume, which can lead to heart failure, okay? In addition to that heart failure, pulmonary edema may be manifested as well, and edema in general, okay? There's buildup fluid within the body. Remember, hypervolemia is in play here. Fluid is everywhere. Next, we move over to potassium. And potassium is not being excreted, which will make one hyperkalemic, and hyperkalemia's manifestations will be evident, such as cardiac irregularities and possible cardiac arrhythmias, okay? So think hyperkalemia's signs and symptoms. It is not being excreted. Our next complication is that of elimination. The kidneys cannot properly eliminate or excrete wastes, and this will lead to uremia buildup. And uremia is a waste product. So if a waste product is not being excreted, it can circulate within the body. When it becomes more and more concentrated, it will furthermore cause GI manifestations such as that nausea and vomiting, as well as the neurological manifestations such as confusion, headaches, and even comas and seizures. All right, so that's very important to remember. Also, guys, due to the lack of EPO release, the erythropoietin from the kidneys, this will cause anemia to be manifested because EPO is what stimulates blood cell production within the bone marrow. Now, there's also going to be acid-base impairments due to lack of excretion of the wastes and buffering within the body, leading to acidosis, okay? Metabolic acidosis because it's within the body, okay? Metabolic. Moving along, the kidneys also activate vitamin D, and vitamin D is what absorbs calcium. Therefore, when kidney disease is present, vitamin D will not be activated. And when it is not activated, this means calcium will not be absorbed. And when calcium is not absorbed, the individual will become hypocalcemic, okay? Low calcium within the body. And remember, calcium and phosphorus has an inverse relationship. So being that hypocalcemia is present, hyperphosphatemia will also be present. And this is also due to the lack of excretion of phosphate, okay? There's a buildup amount of phosphate within the body. Also, guys, being that hypocalcemia is in play, there will also be risk for osteodystrophies, which is bone breakdown, or risk for fractures due to the low calcium. Bones will not have proper stabilization or calcification. Also, hyperparathyroidism will be triggered, and the parathyroid secretes something known as PTH, which stands for parathyroid hormone. It's pretty straightforward. And PTH resorbs bone, breaking it down, making way for new bone. And if it is secreted too much, like in the case of hyperparathyroidism, this will cause hyper breakdown or resorption of bone, okay? So just keep that in mind. Now, the nursing interventions for these individuals are going to be monitoring of vital signs, as always, looking at the blood pressure due to the hypertension and heart rate due to the hyperkalemia. We're also going to want to maintain and keep a dialysis schedule for when it has to be done due to the high levels of everything that's not being excreted. Now, after dialysis, vital signs can go down, so we're going to want to monitor them for that as well, because we don't want them to go too low, okay? Also, guys, checking the labs like our electrolytes and labs that are indicative of kidney function, such as creatinine and BUN. Creatinine is for kidney function, while BUN is for hydration status. We're going to want to monitor those as well to make sure they're up to par. Moving along, if there is a renal transplant that occurred, we're going to want to assess the patient to see if the body accepted the new kidney, and also administer those immunosuppressive medications, which are going to suppress the immune system, allowing the body to accept the new organ. Now remember, guys, a renal transplant in the case of end-stage renal disease is not going to cure the disorder, but it's going to help manage and improve the function of the kidneys or the kidney. Moreover, monitoring and maintaining cardiac monitoring is essential because remember, there's risk for lethal arrhythmias due to everything that's going on, and especially due to the increased potassium within the body. We're going to weigh the patient to monitor if fluid is normalizing, increasing, or staying the same throughout the day. And we're going to definitely want to restrict sodium due to the increased sodium within the body, restrict fluids due to the increased fluid within the body, and restrict potassium due to the high potassium in the body as well. Now, uremia, creatinine, and nitrogen are byproducts of protein breakdown, and they are not going to be excreted when there is kidney damage. So we're also going to want to restrict protein due to the buildup of all of these byproducts, which will complicate those GI and neurovascular symptoms even more, okay? So restriction of protein is going to be important. Lastly, administering medications as ordered is definitely an intervention that's going to assist in decreasing symptoms of renal failure. For example, for hypertension, we're going to give antihypertensives and diuretics. For the high potassium, giving things such as K-oxalate is going to help get potassium out of the system through the GI tract. And for the high phosphorus, giving phosphate binders is going to help bring those levels down. So guys, there's going to be a lot of interventions done when dealing with this disorder. And that is the end of this presentation and the end of the renal series. Hope you all enjoyed this video. Like, subscribe, thumbs up. If you haven't already checked out the other presentations that are a part of this series, you can check it out after this video, starting with the renal overview. And that's it from me, guys. I'll catch up with you guys next time.